you very much. Sorry for that hitch. It's technology always. I don't know why gets us into trouble. So, as Dr. Toyer said, I'm going to talk about initiating dialysis and whether initiating early or late in patients who have AKI in the ICU. Thank you for this opportunity, the KRA organizing committee. I think you guys are doing a great job in doing this webinar and online conference. I know it's a big, difficult task. Well done. So next slide. Okay, so just a little bit of introduction there. Acute kidney injury affects more than 50% of critically ill patients. And, AKI is associated with considerable morbidity and mortality. As you have seen, in our ICU, almost 25 to 50% of patients have AKI. And maybe 50% have AKI, but maybe 20% require dialysis. And out of those 20% who require dialysis, almost 50% end up having a mortality. So, when you're dialyzing these patients in the ICU and people, look at you a bit weirdly because 50% of your patients die. It's not a very good outcome, as you can see. So initiation of kidney replacement therapy is the standard of care when AKI leads to life-threatening complications, as we all know, like severe hyperkalemia, metabolic acidosis, or diuretic resistant volume overload. So there's no question about, those patients who have this kind of issues to start dialysis. However, the optimal timing for kidney replacement therapy initiation remains clear when patients have not yet met those life-threatening conditions. So on one hand, early initiation strategy may theoretically maintain physiological balance and avoid harm from fluid overload and metabolic derangements. As we have now, more studies are coming out saying that restrictive fluid volume is better outcomes. And on the other hand, kidney replacement therapy initiation represents a considerable escalation in care, and it may unnecessarily expose patients to invasive procedures with risk of harm. Obviously, fixing a dialysis catheter is not without harm. That's why we have to take a consent. So risk of dialysis catheter, acute complications, pneumothorax, bleeding, hemothorax, and then, things like infections, reinsertions, catheters not working, etc. And the dialysis itself has its own complications. So we'll look at, what is right, when do we start, and we'll look at a number of, people have looked at a number of trials, which we'll look at them. What does the KDIGO say about this? When do we start dialysis according to the KDIGO? Because, that's our holy grail. So we go there and look at our guidelines. What they say is not very clear. They're saying initiation of renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, acid balance exists. So that we have said, that we know, and that's it's not yet graded as well. But consider the broader clinical context in the presence of conditions that can be modified with renal replacement therapy and trends of laboratory tests, rather than single BUN in creatinine thresholds alone when making decisions. So it's not really helping us. These guidelines are not helping us. What do they define AKIs? KDIGO, increase in serum creatinine by more than 0.3 within 48 hours, increase in serum creatinine to more than or equal to 1.5 times baseline, if the baseline is known, or urine volume less than 0.5 mils per kilo per hour for 6 hours. That's according to the KDIGO. And the different stages of AKI, stage 1, stage 2, stage 3, and at which stage do you start dialysis? Okay, so different studies have looked at different stages, where they start dialysis and what are the outcomes. So stage 1, as you all know, serum creatinine increased by more than 26 to 30 micromole per liter, or serum creatinine increased by 1.5 to 2 times the baseline. Okay, or urine output less than 0.5 mils per kilo for more than 12 hours. Stage 2, serum creatinine more than 2 or 3 times. So easy to remember, stage 2, 2 times. Okay, stage 1, 1.5 to 2. Stage 2, 2 to 3, and then stage 3 is more than 3 times. So it's easier to remember that way. And the serum creatinine, if you come up with a serum creatinine of 100, your serum creatinine has gone to 300, you are in stage 3 AKI. Or urine output less than 0.3 mils per kilo, or anuric for more than 12 hours. So usually when in our local setting, we are called for these patients when, they're almost in stage 3. So it's not very difficult for us to decide on dialysis. And usually they are anuric for more than 6 hours. So, why are we looking at this? Why are we looking at when to start dialysis? Why are we looking at does starting early help in mortality or not? The question is, mortality in AKI, as I previously said, remains stubbornly elevated. And how can we reduce this mortality? What can we do? So how do you decrease the mortality, and whether you start dialysis early or late, does it have an impact on the mortality? So people looked at many things to improve this mortality in AKI, and one of the things they looked at in the early parts of the century is dose of dialysis. Whether higher dose of dialysis is better than the lower dose of dialysis, and this was definitely rejected by the ATM. So it doesn't matter what dose of dialysis you use, outcomes are the same, unfortunately. So now the question moved to the dose to timing, right? From the dose to timing. When should we use dialysis in AKI, and does starting dialysis early in AKI improve outcomes? So the first, amongst the early studies in this after 2010 is the AKI study, as Dr. Tahir alluded earlier. The initiation strategies for renal replacement therapy in the ICU, and it was published in the NEGM, big trial, published in 2016, July. So what is this study all about? So which is the better time for initiation strategies of renal replacement therapy in the ICU? And this is the AKI trial, as I said. It was a multi-center, prospective, unblinded, open-label, randomized trial, involved 31 ICUs. They had a total number of 620 patients who are all on mechanical ventilation. So this study looked at patients who had AKI and had KDIGO stage 3 at stage 3. And usually most of them had ATN, secondary ischemic or toxic injury. And in addition to that, patients were also on vasopressors. So these were randomized, okay? The early, all the patients were at KDIGO stage 3. The early ones were dialyzed within 6 hours of reaching KDIGO stage 3. And the others, were dialyzed when they had the indication for dialysis, so emergency dialysis, and that was the delayed strategy. So early strategy, delayed strategy, okay? 30% of these patients required CRRT, and 55% were on HD, and others were on the rest of the other modalities. So what are the outcomes they looked at? The primary outcome they looked at is 60 days mortality. And as you can see here, 60-day mortality between these two groups, the one for early strategy and the one for delayed strategy, wasn't different. So 312 patients, out of 312 patients, 150 died, and that's 48.5%. And in the delayed strategy, again, similar percentage of patients died, and the p-value there wasn't significant. The interesting thing was, and these are the other secondary outcomes they looked at, whether they required dialysis or not, whether they had renal replacement therapy free days, mechanical ventilation free days, and vasopressor free days. Okay, so we'll look at those patients who did not require dialysis. So, obviously, early strategy, 98% of those patients require dialysis, because you're going to dialyze them before they recover or they die. But in the delayed strategy, okay, almost 50% of these patients did not require dialysis. Okay, so 157 patients out of 308 required dialysis. So if you minus 157 by 308, so it comes around to ballpark of around 150 patients did not require dialysis. So that's almost 49% of those patients did not require dialysis just by delaying. RRT free, and this was statistically significant. RRT free days, again, 17 days for early strategy and 19 days for delayed strategy. Again, those patients who require dialysis, they dialyzed at a later stage. So again, this was statistically significant. Not significant for mechanical ventilation free days or vasopressor free days on both strategies. The conclusion here is obviously, as we have seen the mortality in this trial, involving critically ill patients with severe AKI, there's no significant difference with regard to mortality between an early and delayed strategy for the initiation of RRT. But look at, one thing which comes out obviously is almost 49% of those patients who, if you put them in early strategy, would have dialyzed, did not dialyze. Okay, so just after this trial, a few weeks later, another trial comes out. My computer is slower than the time the trial takes to be done. Okay. So as I said, just a few weeks. So that was in July, and this is in August 2016. So very very rare to get randomized control trials in nephrology coming out, one after the other. So again, this was published in JAMA, the Elaine randomized clinical trial, and it looked at effect of early versus delayed initiation of renal replacement therapy, again on mortality as the primary outcome in critically ill patients with acute kidney injury. Again, I have the similar diagram there. Does early initiation of renal replacement therapy have a better impact on mortality in critically ill patients with AKI? And this one was called Elaine. And Dr. Tahir has a saying that I'm Akiki and he's Elaine. So let's see what Elaine says. So, it was a single center prospective randomized, had 231 patients. AKI, so here they compared AKI, KDIGO. The reason why I gave you the KDIGO classification so that you all know what stage 2 and KDIGO stage 3 is. So they looked at KDIGO stage 2 versus KDIGO stage 3. They also looked at the angle for this to be more than 150. And 80% of these patients were actually surgical patients. Yeah, 80% of these patients are all, most of them were surgical patients and almost 50% were cardiac surgery. So as I said, early strategy was KDIGO stage 2, delayed strategy KDIGO 3. And equally randomized in this, they had 112, and in this, they had 119. And 100%, all the patients, it was a single center prospective randomized, so it was easy. All the patients went with CVB HDF as their modality for dialysis. So they looked at, we looked at 60-day in AKI. We're looking at 90 days here as a primary outcome mortality in this study. And what they saw, interestingly, is in the early strategy, 39% of the patients had mortality, but in the delayed strategy, when they reached KDIGO 3, and then that's when they dialyzed, only 54.7% of these patients had mortality. So there was higher mortality in KDIGO stage 3 versus KDIGO stage 2, and there was some statistical significance. P was 0.03. So as we have seen here, waiting for patients until they reach KDIGO stage 3, outcomes were not good. And again, you can say, a couple of flaws in this trial could be because probably these were more sicker patients than this one. Who knows? But again, you would argue that this was randomized trial, so unlikely to have more sicker patients. So secondary outcome, they looked at time where they required renal replacement therapy until they opened up. And then here, the average was 9 days, and here was 25 days. So if you waited till your KDIGO was stage 3, 25 days for dialysis. But you would argue that these patients would have recovered nevertheless, right? Whether you dialyze them or not, they would have recovered nevertheless. That's why they took less time. Yeah, we'll discuss on that. And then recover again, renal function was better here than here, as I said, and hospital stay was shorter in patients who were in KDIGO 2 than those patients who started dialysis when they reached category 3. Patients are randomized. You would say these were equally sick patients in both groups. So it looks like a very good, study. Patient, if you start dialysis early, before they reach category stage 3, outcomes were good. And the conclusion was among critical ill patients with AKI, early RRT compared with delayed initiation of RRT reduced mortality over the first 90 days. Great. So then, Ellen study done by Zarbok says this early initiation of RRT may produce benefits by avoiding hypovolemia, eliminating toxins, establishing acid-base hemostasis, and maybe that's why the mortality was down and preventing other complications attributable to AKI. However, early initiation of RRT expose some patients to potential harm because some patients will spontaneously recover renal function, as we say. So it didn't end there. Again, we have two trials just opposing each other. Another trial was done in 2008. Those are 2016. This one was published in 2018. And this one was timing of renal replacement therapy in patients with AKI and sepsis. So this was only patients who had sepsis. Okay. And in this study, they used the rifle criteria instead of the Gedigo staging criteria. And rifle criteria, from risk, injury, failure, loss, and end-stage renal disease. Risk is if your creatinine goes 1.5 times or your GFR increases by 25%. Injury is 2 times, more than 50%. Failure is 3 times. So you could say failure and stage 3 could be similar to each other. Okay. So they used patients who are in this category. So again, a similar schema. I like these schemas because they're easy to explain and easy to understand. Is there an ideal time to start renal replacement therapy in patients with AKI and sepsis? And this study was called Ideal ICU Trial. Elaine AKI very well, commonly known from the nephrologist perspective. The Ideal ICU Trial, more critical care guys know about it, but it's good to look at it as well. So it was again multi-center controlled, open label, 2-group randomized, and they looked at 29 ICUs. Total number is 488. And I said, they used the AKI rifle criteria and they used at the failure stage, and patients should be in septic shock, not AKI secondary to anything else. AKI in septic shock. So then, these patients were randomized equally into early strategy and delayed strategy. Early strategy, as you know, both these groups, the patients line rifle class or stage F failure. Okay, but in early, immediately when they reached in that F class, within 12 hours, the patients were started on dialysis. That's early. Okay, and in the delayed, they waited for 48 hours, so more than 2 days, and the patients are still in that rifle stage, and that's when they started dialysis. So patients, if some of them even started dialysis at 60 hours. So again, RRT initiation almost equally distributed. 56% required CRT, and 44% were requiring hemodialysis. So again, the primary outcome was mortality, 90-day mortality. And as you can see, in whether you start them at early, as soon as they reach the F failure stage, less than 12 hours, you start them on dialysis, and more than 48 hours, the difference there's no difference, right? Mortality is the same, 58% versus 54%, and the p-value is 0.38. So again, another trial, again starting early dialysis. Secondary outcomes, receipt of dialysis, as I said earlier, interestingly, in this stage as well, in the F stage, in the failure stage, patients recovered if they were not dialyzed within 12 hours. So as you can see, okay. So obviously, if it's early, it's less than 12 hours, okay? All the patients would be dialyzed, right? Less than 12 hours, you've reached F, you would dialyze, you don't wait for recovery. And in the delayed strategy, they waited for more than 48 hours. Almost, out of 238, 149 of them required dialysis. If you subtract that, my maths is not very good, but at least 100 patients recovered without requiring dialysis. So 97% required dialysis in this group, whereas 62% required dialysis in the delayed strategy. And the p-value is quite significant, less than 0.01 if you compare these two groups. RRT free days, again, statistically significant. MVA free days, not significant. Vasopressor free days, not significant. So the conclusion here again was in patients with septic shock, these patients are in septic shock and who have severe AKI, there was no significant difference in overall mortality at 90 days between early initiation of renal replacement therapy and the strategy of delayed initiation. So, when we are in a rush, we say, oh, this patient, doesn't have acute, like 100% indications for dialysis. Or why didn't you start dialysis within 12 hours? Maybe there's a blessing in disguise, the patient might recover. So, okay, I don't think I'll go through this because it's a similar thing how the patients were randomized. This is the ideal ICU. So, just a brief summary of what's happening. They had almost 4,000 patients. Inclusion criteria were around 1,700 patients. Lots of exclusions here. Mostly, patients who received emergency replacement therapy. Again, were not in this study. So, and then 488 went randomization, 246, 242 in each group, and the rest we have discussed in the previous. So again, as I said, mortality. This is a Kaplan-Meier curve looking at overall survival among patients assigned to early versus delayed. Wasn't significant. See my cursor there. This is proportion of surviving patients and days since randomization, and the blue one is delayed strategy and the red one is early strategy. As you can see, the curves are quite touching each other. Then, finally, I think this is the nail to the coffin. Timing of initiation of renal replacement therapy in AKI, and this was the START AKI trial done in mainly, the investigators from Canada and USA. I took part in the pilot study initially. We actually we were allowed to participate here locally, but some logistical issues, we couldn't participate in this trial. So it's a multinational, multi-center trial, and they randomized around 3,000 critically ill patients, and with KDIGO stage 2 or 3 AKI to either accelerated or standard kidney replacement therapy strategy. And they had a couple of exclusion criteria, which I've mentioned here: potassium more than 5.5 or bicarbonate less than 15, kidney transplantation. So the reason why they excluded these patients is because this patient required dialysis urgently. Kidney transplantation in preceding year, advanced CKD, which was defined as GFR less than 20, or presence of overdose of dialyzable toxin, then you can't wait for dialysis, or strong clinical suspicion of kidney obstruction, vasculitis, TMA, or acute interstitial nephritis. So those patients were all excluded. And then, then those who we were not very sure whether we should dialyze or not, these were patients then who are subsequently randomized. So in the accelerated group, clinicians were urged to initiate KRT as soon as possible and within 12 hours after randomization, whereas in the standard group, clinicians had discretion to initiate KRT at any time based on their clinical judgment, but they were provided general guidelines for initiation of KRT. Okay, that's kidney replacement therapy, including if the potassium went more than 6, if the pH went less than 7.2, if your bicarbonate went less than 12, and if your PaO to FiO2 ratio went less than 200, or clinical perception of volume overload or persistence of kidney injury 72 hours after randomization. So I hope that is clear. Those patients who are in accelerated group, started dialysis within 12 hours, but those who are in delayed or the standard group, they had to meet these guidelines or clinical judgment. So they had to meet these indications for dialysis or the clinical judgment of the doctor if they require dialysis. So among those receiving kidney replacement therapy, therapy was initiated at median time of approximately 6 hours in the accelerated group, whereas in the standard group, it was around 31 hours. So notably, interestingly, 38.2 patients in the standard group never initiated KRT, just similar to the previous studies we have looked at, compared to 3.2% in the accelerated group. And the groups were similar with regards to initiation of renal replacement modality and anticoagulation, equally distributed between whether they needed CRRT or hemodialysis and whether they needed heparin or citrate. So look at baseline characteristics of this accelerated strategy versus standard strategy. You look at all these baseline characteristics that, I won't go through each one of them. They're similar, okay? They're quite similar to each other. So what are the outcomes? The primary outcome again here was death from any cause at 90 days, okay? So in the accelerated group, there are around 1,400 patients. In the standard group, around 1,400. So equally distributed. So 643 patients died here and 639 patients, so 43.9% versus 43.7%, and the relative risk was 1. So equal mortality in both groups. So then they looked at the secondary outcomes, whether RRT dependence among survivors at 90 days. If you started early, would you come off dialysis at the end, or would you continue dialysis? Okay, so in the accelerated group, 10.4% of the survivors still require dialysis, and in the standard strategy, 6%. Again, not statistically significant. Death or RRT dependent at 90 days, again, not statistically significant. Pass through that. So again, the Kaplan-Meier curve, estimate of survival at 90 days, both the standard replacement renal therapy was accelerated, no significance at any days at randomization, right? Meeting each other. So they looked at other subgroups, whether male or female make a difference. If your estimated GFR was less than 45 or more than 45, would that make a difference? And as you can see on this chart, the left side is accelerated strategy is better, and the plots on the right side, standard strategy is better. And you can see all these lines are crossing, okay? So none of the subgroups also showed a difference. So, whether your SOFA score, they looked at the SOFA score as well, whether you had a worse SOFA score and if you started early versus you started late, whether it was sepsis, whether it was surgical or medical, ICU, and even geographical regions, it didn't make a difference. So in summary, does early initiation of kidney replacement therapy decrease mortality? Again, as I said, huge trial, 168 hospitals, 15 countries, randomized from 2015 to 2019, and all these were kidney patients critically ill with severe AKI stage 2 or 3, okay, around 3,000 patients. So standard strategy, accelerated strategy within 12 hours. Standard, you had to do that. You have to have the indications for dialysis, okay. Mortality was same, KRT dependence was same. Adverse events were actually more in the accelerated strategy than the standard strategy. So this is something to look at. So what they concluded was among critically ill patients with AKI, an accelerated renal replacement strategy was not associated with lower risk of death at 90 days than a standard strategy. And I think this just, nails the coffin. Okay. So the question comes is, what if we can predict which patients require kidney replacement therapy? And, an interesting finding in the START AKI trial was that nearly 40% of the patients in the delayed group did not require kidney replacement therapy, okay? And similarly observed in the ideal ICU, where it was 38%, and AKI trial, as we said, was around 49% of these patients in the delayed group did not require dialysis. And, they agree that avoiding renal replacement therapy is better than unnecessarily starting replacement therapy, as it has increased complications. So all these trials and the previous small trials were put into a systemic review and a meta-analysis of all the randomized clinical trials. And here's the first plot here. And again, this side is favor delayed, favors early. All these trials fall in between this line. So none of the trials shows a mortality benefit at 28 days. Again, they divided whether it is in all these trials. They looked at the age difference, the SOFA score, less than 12, more than 12, no difference. If you're old or young, no difference. If you're sepsis or no sepsis, again, no difference. If you had chronic kidney disease, yes or no, again, no difference. So that's a summary chart of all the trials we went through. We went through the ELAINE, the AKI, the IDEAL ICU, and finally the START AKI trial. And finally, I showed you the systematic review. So how do we? The question comes back again. How do we, improve our mortality in AKI? So dose doesn't matter, time doesn't matter. What matters? I think what matters is getting these patients early and preventing the AKI to occur for us to require dialysis. And if we can prevent that, then our mortalities would be better. Thank you. I think I had a slide, last slide, but it's not there. About the take-home messages. So our take-home messages are, as I said, most of our patients in our ICU, in our local setting, we are only called when we really absolutely require dialysis. When you're not sure, whether you require dialysis or not, early dialysis for mortality benefit. And then, things we need to do is more of prevention, avoid nephrotoxins, prevent patients getting into a state of AKI requiring dialysis. Thank you very much for the opportunity.